So now look at all this, right? So blue pulmonary vein, deoxygenated blood coming from your right atrium into the lungs, going into the lungs. All these oxygen exchange happens because you have capillary interstitial space over there and capillary membranes participates in gas exchange. Oxygen-rich blood goes back into pulmonary artery, back into the pulmonary vein. So that's how the whole system works. You already know that. Now, if you look at the space here, so now go to the next picture, which kind of gives you an idea of what we're looking at. This is your normal side of your alveoli, okay? You have type 2 cells, which is the alveolar type 2 cells. There's type 1, type 2, whatever, doesn't go into too details. Just the purpose of these is to produce surfactant. So as a baby, less than 28 weeks, some of you pediatric folks can correct me. I think your surfactant production in your body doesn't happen until you're 28 weeks, I think. So that, I think my daughter had bigger surfactant when she was born prematurely. But long story short, adults have this, right? Once you have the surfactant, guess what? That's the one that prevents your lungs from sticking, okay? But what happens in pneumonia? Your alveolar type 2 cell, what happens in smoking? All these inflammation causes destruction of these cells, right? Now guess what? Think about this as pneumonia. This is pneumonia picture. Look at all the fluid buildup in here. Okay, over time, all these macrophages, all these basal cells, or WBCs, they come in and they try to clean up. But guess what? Where did the debris go? The debris doesn't just get washed out. You don't literally suction WBCs out of patient's lungs. It gotta go somewhere. It eventually forms, I think this is stage 4 in the ARDS presentation, but it eventually forms what's called the hyaline membrane. Okay, look at the thick layer of this membrane. Now this prevents from gas exchange from happening, okay? How do I fix this problem? Because I don't want patients to go home like this because then he'd probably end up needing a lung transplant. What do I do to fix this? Pulmonary toileting. Increase in PEEP, increase the surface area, wash it out, pulmonary toileting. What does pulmonary toileting means? What do you guys think when you were saying pulmonary toileting? Like bronchodilator, right? Suctioning, CPTs, steroids, So that's why patients who are in ARDS picture never gets extubated on day 3, right? Because they progress into these spaces over the course of 14 days, and that's why sometimes some patients who are detrimentally sick, where it's a very bad ARDS, they are intubated for 14, 15 days and trach after that. Because their lungs need so long, even when rehab, they need so long to clean up this junk, right? Oftentimes, I know during COVID times, I don't know how many of you guys witnessed patients with severe bad lung injury going home 3 months later, coming back with pneumo. Why? Because their lungs are so torn apart with massive amount of PEEP, so much secretion, their lining is so thin, any cough could cause a pneumo. Think about that, right? One patient that I had 4 chest tubes, upper, lower, everywhere. I mean, I don't think that patient made it. But, okay, so next slide. One of the benefits is it increases functional residual capacity. All that FRC means is the amount of volume that is left at the end of exhalation, the amount of volume of air in respiratory terms. Prevents atelectasis. It prevents pulmonary shunting, VQ mismatch. What's your understanding about VQ mismatch?
So this is for the amount of oxygen that can be circulated within the lungs for like what you're getting for volume with PEEP. There's a mismatch for it, so there's not enough circulating capacity to
well
fully oxygenate everything else. So that's why it's the mismatch.
Yep. V for ventilation, Q for perfusion, right? It's a common term. They said, oh, it's intropulmonary shunting. Basically, like she said, basic thing is I'm giving ventilation, I'm giving a set respiratory rate, I'm giving a set tidal volume, I'm giving set PEEP of 15, whatever. My ventilation is happening. Is my perfusion happening? What do I mean by perfusion? Previous picture. Lung alveoli are here, capillaries here. Big hyaline membrane blocking the whole passageway. Nothing is perfusing through. So what do I do? So now I have an intropulmonary shunting. So what do I do with PEEP? Increase the surface area, mobilize the secretions, whatever turn positioning, and then I can increase the surface area and then increase the distribution of gases, right? Improves lung compliance. Okay, so let's move on to the next one. Now, we talked about the benefits of PEEP. I'll talk about FiO2 and PEEP and stuff, but Lisa's point, how do I figure out? I'll tell you that in a second. But let's talk about the adverse effect of PEEP. Especially cardiac patients, Stacy, you work open heart nurse, you work with those patients, you will oftentimes running into, I don't think, most of the time your patients now are high PEEP anyways, right? Just not
Only if we get to that situation where we can't oxygenate.
Gotcha, makes sense.
Or they're bleeding sometimes. Yeah.
True.
And only slow amounts of it.
Gotcha. Yeah, so one of the biggest things, you don't necessarily have to be intubated for this.
Dr. Parentis?
Yeah, you don't necessarily have to be intubated for this. PEEP decreases cardiac output. How does that work? How does PEEP decrease cardiac output? Anyone? Just throw in anything you can think of. Yeah, dilates everything in a sense where what does the cardiac speak to? So normally, okay, have you guys ever thought about how does your blood from your toes, your feet, your calf, how does the blood come to your heart? Anyone thought about that? Like, how does that work? You know, like, how does the body have to pull all that fluid or blood, deoxygenated blood back into your right atrium? How does that work? A, muscle contractions, right? That's what we mimic SCDs to, you know, pump up the blood. But then there's a long passageway. I have to travel all the way from my feet all the way to the heart. So the way this works is the way that our body is designed to bring all the blood back to our heart is very, very interesting and fascinating way of thinking about it. When you take side breaths or when you take deep breaths, okay, nice inhalation, okay, side breaths, what happens is, in medical terms, it increases the intrathoracic pressure, okay, or pressure inside the lungs. It contracts your diaphragm, and it in turn compresses your abdomen. When it compresses your abdomen, guess what? Guess what's behind your abdomen? Inferior vena cava. Okay, big, large vessel in charge of bringing all the blood back. It's so cavernous in nature, it's very cavernous in nature, it can hold a lot of blood. What happens is, with the muscle contraction, with the SCDs and all that you're laying blood will eventually make it to the inferior vena cava. But how does it make it from the inferior vena cava to my right heart? Because it's all ready to be dispelled, you know? The way it works is when I take a deep breath, when my diaphragm contracts and my abdomen pushes it compresses the inferior vena cava, which in turn pushes blood back into my right heart. So that's how my cardiac output, your blood pressure, everything stays normal from circulation. And then it just pushes back into circulation again. Guess what happens to patients with high P or positive pressure? Doesn't have to be high P. Just think about BiPAP. Anytime I put a mask on someone's face, anytime I put a tube into someone's mouth and ventilate for them, the term we use is called positive pressure, okay? If you're taking a breath on your own, it's called negative ventilation. That's a term, so don't get confused with negative and positive. If I'm forcing air into someone's lungs, it's considered positive ventilation. BiPAP, the same thing. What does BiPAP do? What does high volume and high PEEP does? Is that it increases the tidal volume, increases the pressure in my lungs, increases the intrathoracic pressure, and guess what? It constantly compresses my diaphragm, constantly compresses my abdomen. In turn, it constantly compresses my inferior vena cava. So now my vena cava is not completely compressed, but compressed enough that you think enough blood can come back and store in my inferior vena cava. No. So guess what? Blood return back from the extremities to the heart decreases. So if the heart is not having enough blood, what happens to my blood pressure? It drops. So let me throw in some scenarios here. So oftentimes I've seen, many times during my respiratory times, anytime, you know, there's a very, very sick patient, borderline septic, you put them on a BiPAP, guess what the first thing happens? Their blood pressure drops. And you're like, oh my God, what did I do? I just put the BiPAP on, why did my blood pressure drop? So your goal is to not to give them so much positive pressure. If you think this patient needs positive pressure, then intubation is the only way, because guess what? You technically don't want to, you know, run levo when somebody is actually like, I mean, you can technically, but you know, ideally you want to intubate and sedate and paralyze and all that, and then take over their blood pressure and all that. So the goal is always not to keep them on high PEEP, because again, it can affect your cardiac output. If you run into situations like that, you need high PEEP, okay? You're like, okay, doc, my pressures are dropping, he's intubated, I know PEEP caused it. What do you do? What do you suggest? What if it's a new resident that doesn't know what he's talking about, or she's talking about? What do you recommend? No, that's gonna dilate even
It's gonna
more.
dilate more.
But that's a good,
I
you
guess
know.
it depends on like why they're being intubated for what. I mean, if you can't decrease the PEEP, then you're gonna have to support with either fluid boluses or
Yes.
pressors to help
Yes.
with that with
Yes, right? 100%.
vasoconstriction.
Exactly. So you know what caused the low cardiac output is sometimes CHF, right? Or cardiogenic shock, who knows what. But then that's when your knowledge of comes in and say, you know what, doc, I think based on the current presentation, we need to start him on levo. We need to maybe with CHF then try not to give more fluids, you know. So you determine what needs to be better for that patient at that time. It's a temporary fix, right? Once the patient's off. Literally, I took care of a patient the other day. Peak of 15. The minute we dropped the peak of 15 from peak of 2 down to 8, guess what? Man, the volumes improved, the blood pressure improved. We didn't even have to start levo, you know, for that reason. So think about all that, okay, when you're playing with event settings and stuff. Okay, we're going to move on to the next setting. Okay, flow rates, which I will go over flow rates shortly. Not going to touch too much on the flow rates now, but I'm talking about different modes. I can explain flow rates in more. But just know flow rates are, designed to deliver tidal ones at a faster space plus slower pace, depending on how you set it. But we can just keep it for now. IE ratio, again, is one of those things I'll tell you quickly. What is IE ratio? What is your IE ratio? Do you know what IE ratio means? Anyone? Inspiratory to expiratory time. Do you have an IE ratio? You do? What is it? Yeah, so 1:2. Just normal, because 1:2. Very basic. So what does 1:2 means? Okay? Inhalation to expiratory ratio. You and I, guys, we all have IE ratio 1:2. That's the way our body is designed. Means 1 second to inhale, exhalation is twice as long. You don't think about exhalation because exhalation is passive, right? So I take 1 second to inhale. I don't think about exhalation. My exhalation goes slowly. I don't exhale like that, okay? So theoretically, knowing that any normal human being should have a IE ratio 1:2, in certain situation, okay, I'll tell you this. In COPD patients, I cannot mimic the same IE ratio. Can I have their inhalation time 1 second and exhalation time 2 seconds? What should ideally then their IE ratio be? If you know they take longer time to exhale because they have obstructive pulmonary disease, obstruction on the way out, what do I need to set their IE ratio, expiratory time to? 1:3. 3 times as long as you and me. What about ARDS patient? Do they have, can I increase my inhalation time? Can I shorten my inhalation time? What is the IE ratio for the ARDS patient? It's because their lungs are stiffer in nature. Their IE ratio is the inverse, we call it inverse IE ratio, which means they're going from 2 to 1, which means I'm going to take longer time to inhale, longer time to put that air in your lungs, okay, and less quick time to exhale, because guess what? If I jam that volume of air quickly over 1 second, guess what's going to happen to that stiff lung? Exactly. So they always use the inverse ratio. So anyways, how do I manipulate all these settings? Through my peak flow, which I'll tell you again in detail when we work on this more. Okay, let's get on to the next one. Okay, let's talk about the fun stuff, the FiO2. So, all right, so before you start playing with these settings here, I know most, again, bear with me guys, most of this is redundant, you guys already know this, but anyways, why not, just a refresher. So, FiO2, right? FiO2, you crank it up to whatever, 40%, 50%. Before you start getting into FiO2 world, you need to know the basics of the numbers that you're looking at ABG. Because if I'm looking at ABG and I don't know what I'm looking at, then what's the point of looking at it, right? SaO2. What does SaO2 mean? And the amount, when I do an ABG, there's a number you can see is called SaO2. There's also another one called SpO2, which you guys also do it. But for arterial purposes, let's focus on SaO2. When I do an ABG, you will see called SaO2 on there. Typically, you see a percentage number next to it. It's the amount of oxygen that is bound to the hemoglobin, okay? Amount of oxygen that is bound to the hemoglobin, because hemoglobins are the carriers of oxygen. And say, hey, here you go, okay, take the oxygen to the tissues, right? PaO2, on the other hand, when you do an ABG, oftentimes physicians will ask you, what is my PO2? Also known as PaO2, partial pressure of oxygen, which is the amount of oxygen that is dissolved in your entire blood, okay? When my lungs brings 21% oxygen, when it goes into the bloodstream, if I do an ABG on you guys, your PaO2, your amount of oxygen-rich blood in your entire blood, not just your hemoglobin, should read what? 80-100. That is a normal. Just know the normals, right? 80-100. Now, the question arises is, when patient is intubated for, let's say, pneumonia, in the perfect world, if I do an ABG on you, I want a perfect world in the critical world, I want a PaO2 of 80-100. But can I ever achieve a perfect number in the ICU? I mean, realistically, I want to. I'm going to do my best I can, but what is my limiting factors? All the secretions you saw on the previous pictures, all the nasty stuff, right? So I'm never going to get a picture perfect PaO2, even though that's a normal. Then what do? Is there a critical number that you're looking for? Then okay, this is absolutely no go. PaO2 of less than what? 60. That's why oftentimes physicians don't panic when you see a PaO2 of less than 80 or PaO2 of 70. They go, okay, all right, okay, I got some time, not much time, but I got some time. PaO2 of less than 60, which means your patient is in now what's called hypoxemic respiratory failure, okay? What do I mean by that? the amount of circulating oxygen in the arteries is less, is low. It's supposed to be between 80 to 100. Why? There's a ventilation perfusion mismatch, right? Pulmonary shunting. So guess what? If it gets less than 60, that means if my amount of oxygen-rich blood in my blood is low, what do you think is going to happen to my tissues? Do you think my tissues are having enough oxygen? No. What is the term for low oxygenation of the tissue is called? Hypoxia. Hypoxia. Hypoxemia leads to hypoxia, which means lack of low oxygen in the blood leads to low oxygenation in the tissue. That's why physicians are now almost like, oh my God, it's less than 60, we need to do something. So let me throw in a scenario. So your PA, which is less than 60, you're the ICU nurse, patient is intubated, what would you do? You address the concern to the physician. What are you thinking? What are some of the arsenal that you have in your toolbox that you can do?
Use that FiO2.
Okay, very good. That's number one choice, right? FiO2, now let's say crank it up to from 80 to 100%. You do the ABG in 15, 20, 30 minutes, still less than 60. What's my next move? Okay, physician says, you know, I'm comfortable no more than 15. So you're right now at 15. 30 minutes later, pH is still less than 60. We did already.
Oh, you did.
Huh?
Yeah, proning.
Yeah, before proning, what else? You're getting there. Before proning, what else can you do? From your toolbox.
Turning them, like if you can turn side to
Okay.
side to help get,
Okay.
shift some of that fluid. to
Fluids,
help
very
with
good.
that.
Yeah, non-invasive interventions. Yeah, okay, very good. What else? What's the presentation of this patient looking?
Not good.
This patient's lung short. So internally, what are you thinking? When a pH less than 60, what are you thinking internally? What is happening to the patient's lungs? Arch, right? You're getting there, or you're thinking, okay, my God, this patient's lungs are not compliant, not elastic, not loose. Something is stiffening the patient. I don't know what it is. I don't know if it's bronchospasm, because blood maybe needs a bronch, who knows what. Something is going on, right? So if my lungs are constricted, do you think I'll breathe? What will be my breathing presentation be? Tachypnic. How do I control that? Sedatum, right? So your arsenal, your toolbox is like, hey, I can increase my sedation. Most commonly used sedation is what? Propofol, right? It relaxes you. Now, can propofol bring your respiratory rate down?
Bring your blood pressure up more than anything.
Yeah, it can sedate you, can put you in a nice, comfortable sleep, not necessarily a respiratory rate. So if I'm still breathing like that,
Morphine.
what do I need to add?
But,
Fentanyl. Fentanyl. Why fentanyl, guys? Analgesic effect. So think about fentanyl, right? What do I accomplish? Killing two birds with one stone, right? What do I accomplish with fentanyl? Fentanyl, I know it's an analgesic, it's an opioid, right? It can control the pain. So poor guy, he's intubated, you know, he's like suffering, you know, he's like semi-sedated, but he's also like hyperventilating, so I need to control the hyperventilation. But I have managed the pain, combination with sedation. What is the side effect of fentanyl if I'm not intubated? Respiratory depression. What's a beautiful side effect of fentanyl when I'm intubated? Bingo. So guess what? I'm going to target fentanyl. Again, new practice, you know, trying to avoid fentanyl from opioid dependency and all that. But if you're in an acute state, oftentimes combination of propofol and fentanyl, I can achieve the perfect balance of sedation and ventilation, right? This is where RTs will come and knock at your door and say, nurses, you got to do something. You're like, no, it's your department. You fix the ventilator. Something is wrong with your ventilator. You know, how many times you heard that, right? The nurses say, it's your wrong. There's something wrong with your ventilator. No, I maxed out all my settings, guys. Now it's up to you. What can you do as a nurse, right? Bring your toolbox, open it up, and say, okay, I can sedate him. Maybe hopefully that will relax him. I can give him some more fentanyl, maybe morphine pushes, whatever to control his respiration. Okay. Nice and relaxed. If none of that works, then what is my third drug of choice? Paralytics, Cistercic, Vex, whatever you want to do it. Paralyze even more. Completely muscle relaxant. If that doesn't work, what else am I going to do? Flip them, right? So PaO2, right? One simple number kind of determines which pathway you're going to take. Now let's talk about ARDS, right? How do I know if a patient is an ARDS? How do I determine that? PF ratio. Yes, and especially in the NP world, you guys will oftentimes check into the PF ratio. What does PF ratio basically mean? See, PaO2 divided by FiO2, okay? Ideally, normal world, your PF ratio is between 380 to 476. Even physicians would say anything greater than 300 is okay, they're happy with it. PF ratio less than 300 or 200 to 300 is called ALI, ALI or ALI, whatever you want to call it, acute lung injury phase. Okay, PF ratio less than 200, you're in the ARDS territory already. So anything less than 200. So how do I determine that, right? So let's just say he's intubated. These are examples. You're intubated, lungs are shot, everything is pneumonia, whatever. I do a blood gas on him. He's on 80% FiO2, and I did a PaO2 ABG on him. His PaO2 is reading what? 60. What I'm going to do is I'm going to take that 60 divided by FiO2, which is 80%, which is 0.80. If it's less than 200, that means guess what? I am giving him 80% FiO2, which theoretically, how much should he normally breathe? 21%. I'm quadrupling the amount that he's getting and pushing that into his lungs. And guess what, guys? Even after that, my PaO2, in 21%, my PaO2 should read 8200. Agree? But in 80%, his PaO2 is still garbage. Still reading less than 60. That means what? Severe leaky mismatch. So he's not ready to come out of the woods yet. Not at all. So we need to blood them. We need to pulmonary toileting, paralysis, sedated, you name it. You know what I mean? So that's how they determine PF ratios often. That's one measurement, though. There's other measurements, but typically, depending on which hospital you work, some physicians are all about PF ratio. Dr. Jordan, I think he likes it too, but not seldom he uses it. But once you know the PA, which is less than 60, then it's pretty given. So, any questions on that before we move on? We good? Okay. All right. Let's go to the next one. All right. So. Okay guys, let's talk about FiO2. Now, oftentimes physicians will say, okay, let's lower the FiO2 down. You know, too much oxygen is not good. Why is too much oxygen not good? You know, in the pediatric world, you know, in the neonatal world, if you give too much oxygen to these patient population, they can have retinopathy, blindness, right? Right? Yeah. In the adult world, how does that work? Because we don't often see them going blind. But what else internally happens to them? See, without going into the nitty-gritty of pathophysiology, but think about it this way, like, if you have too much oxygen, let's say 80% oxygen sitting in your lungs, okay? Oxygen stimulates the endothelial cells, you know, just going into the two details, into production of nitric oxide. Nitric oxide in a general sense is good for you, right? You know, vasodilates and all that kind of good stuff. But if you have too much of that, oxygen interacts with nitric oxide, produces a superoxidant, very, very free radical, perinitrate, something like that. So what happens is when you have that superoxidant floating in your lungs, it will literally cause cellular death. It causes cellular necrosis, damage, injury, you name it. It causes chronic damage, chronic inflammation. So you're trying to control inflammation from sepsis. Now you have more inflammation from giving too much oxygen. So theoretically, your goal is to bring the FiO2 down to the least acceptable number as possible. What is the FiO2? So how do I determine, okay, you know what, guy, I don't think this guy needs 80%. I think he can do 60%. How do I know that? How do I determine that?
Looking at the whole picture, looking out at his respiratory rate, what is his SpO2 at? Is he
Yes.
most comfortable?
You said it. SpO2. What should my SpO2 be? Yeah, 94 to 95. Ideally greater than 94%. So theoretically, 94% is what I need. But in COPD patients, can I keep the same standard?
No.
No. What is it, 88 to 92? Right. The other thing that we often don't run into is called absorption atelectasis, right? High oxygen can cause absorption atelectasis. What does that mean in fancy terms? Is basically all it is like, think about it this way. When you're breathing in room air, you're not just breathing in 21% oxygen. What else are you breathing? What else is in the atmosphere? Which is what? Nitrogen, maybe trace amount of CO2, trace amount of helium, argon, you name it, right? But the major concentration of molecule we're breathing in is nitrogen, which is I think 78, don't quote me on it, but I think 70 to 78%. The 21% is oxygen. Guess what? If I were to just give you oxygen, okay, what's going to happen is oxygen readily absorbs from the alveolar into the capillary membrane. It quickly absorbs. Molecule size is easily absorbable. That's why oxygen is so diffusible in the lung space. Nitrogen, on the other hand, is a larger molecule inside, so it doesn't always diffuse into the alveolar space, right? Into the capillary. So oxygen goes in, nitrogen stays, and keeps what? Keeps your alveoli open. Think about the multiple factors at peak of 3 to 5. It's not just your surfactant that's keeping your lungs open. The oxygen, the nitrogen that comes into the lungs also keeps the molecules from dissipating into the tissues, keeps your lungs open. Make sense? Now imagine this. I'm putting this guy on 100%. Do you think he's getting any nitrogen? What is he getting 100% of? Oxygen, pure oxygen. So I don't know if you guys ever noticed, there's two things in the back, yellow and green. Yellow means it's coming from the air compressor sitting outside, which means air, which again consists of nitrogen, oxygen, helium, whatever. Green is pure oxygen, right? Universal color green, pure oxygen. So if I crank this up to 100%, the green hose kicks in and just delivers pure oxygen from the outside source, wherever it's coming from. Guess what? Does pure oxygen have nitrogen in it? No. So guess what? If I were to do that and just keep it 100% pure oxygen, remember the absorption capabilities of oxygen? It quickly absorbs in on normal lungs. And he can cause atelectasis. But if I'm just getting pure oxygen, if I'm absorbing quickly, do you think I can keep it open, my alveoli? Because there's not enough gas, other gas to stay in there without penetrating into my capillaries. Does that make sense? So absorption atelectasis is a term, we don't often always use it and say it out loud, but it is a thing. And just to keep in mind, giving too much oxygen is not always a good thing. So ideally, you want to keep it stats greater than 94. COPD patients anywhere between 82 and 92. 88 to 92. Okay, let's move on. Okay, so the fun stuff. Now I know I have the settings here. Now I need to see what are the patient measured parameters are like. So let's talk about minute ventilation, okay? You can go to the next slide. There's minute ventilation, peak inspiratory pressure, and plateau pressures. The three things, most importantly, that you guys will, as nurses, will be looking at is peak pressures and plateau pressures. Oftentimes during nursing rounds, they will ask you what my peak pressures are at. Minute ventilation is the amount of volume of air that is delivered to your lungs over 1 minute. Remember, every 5 seconds, this patient is getting a breath of what? 500 cc, right? Or if the respiratory rate is set at 12, 60 divided by 12 is 5 seconds. So if every 5 seconds, the patient is getting a breath of 600 or 500 cc. But if you calculate that over a minute, your minute volume, amount of air that's going over a minute, should be between 5 to 8. That is your average for you and me and all that. So it's technically respiratory rate times tidal volume. High minute ventilation greater than 8 or let's say 10, 12 is not always a good thing, because guess what? If I'm pumping up my respiratory rate fast enough, what's getting blown out? CO2. Can I blow off my CO2? Is it a good thing if my CO2 is less than 35? See, our human body is designed so engineered perfectly, right? Everything has a reason, everything has to stay normal to function effectively. But the minute the variables change, go from high to low, everything causes chaotic situation in our brain, in our vessels. It's interesting, they call it the Bohr effect. Basically what it is, if you have low CO2 is important to help help oxygen detach itself from the hemoglobin, and when it comes to the tissues, it releases CO2 helps release oxygen from the hemoglobin into the tissues. Boom. And then CO2 gets into the transport system and gets into the lungs, and we exhale it. But if you have low amount of CO2s, guess what? It will prevent oxygen from releasing itself from the hemoglobin. Does that mean your tissues are having enough oxygen? No, hypoxia, right? So that's one thing, right? So that's important to know. And also what happens in the lung situation, if you're hyperventilating someone too much with a respiratory rate of 28, and this pH, ABG, CO2 reading 32, 31, guess what? It causes vasoconstriction in the lungs, right? You're not supposed to have low CO2 can cause vasoconstriction in the lungs as well. So you're not actually helping the cause. So it's important to titrate the respiratory rate accordingly and make sure you communicate with the physician with the ABG results that you're getting as well. So on and so forth. So that's where the minute ventilation comes in. So physicians will manipulate the settings based on what the average minute ventilation should look like. Okay, so let's move on to the next one. Now, plateau pressure, guys. So this is where sometimes it can get confusing, even for RTs and whatnot as well. Plateau pressure and peak pressures, okay? So I'm trying to explain the best I can. Plateau pressure basically means there's so many pressures in our lungs, okay? There's airway resistant pressure, there's alveolar pressure, my God, Anyways, so there's so many pressures. The most important thing about plateau pressure measures the amount of pressure that is built in my lungs. No, not my lungs, right here. My lungs. That's a big lung. I'm getting tired already. So lungs, the amount of pressure that's built in your lungs, okay, at the end of my inspiration. So let's say I take a deep breath, hold my breath for 10 seconds, and the machine calculates the pressure, okay, amount of pressure that is inside my lungs, which means it includes my alveolar pressure, which means the pressure that is needed to open the alveoli space, the sacs. The elastic resistance, right? How stiff my elasticity is. If it's stiffer for hearts, so I need more pressure to open the lungs. So it's basically asking, okay, what is my internal pressure of my lungs? Why do I need to know the internal pressure of my lungs?
So that has to adjust your peak and what, like, your movement.
Exactly, right? And also, high pressure means lungs are getting stiffer. Because high plateau pressure of greater than 30, okay? When you put inspiratory hold, which I'll show you in a second, when you put inspiratory hold, if it's reading greater than 30, that means my internal pressure, not my tube resistance, not my thinking of the tube, the pressure just purely from my lungs is high. That means either A, my alveolars are going into the atelectasis space, there's more secretions, he needs to be prone, ventilator's having a hard time pushing the air in, okay, maybe his hearts are kicking in, it's getting worse, stiff lungs, multiple factors can happen internally. So if my plateau pressures are greater than 30, know this, that means it's an internal problem. Okay, not a ventilator problem, it's an internal problem, right? So we need to paralyze sedate, whatever. So the goal is always to keep it less than 30. Remember, we talked about compliance. High compliance means lungs are elastic. Normal compliance means like your lungs and my lungs, it can expand and recoil without taking too much time. Low compliance means stiffer lungs. If I have low compliance means my plateau pressure is going to go high because my pressure in their lungs is taking too much to open the lungs. Okay, let's move on to peak pressure. So peak pressure on the other hand, okay, so peak pressure is the amount of pressure that is needed to push a volume of gas into the patient's lungs, okay? So the way I say it, peak pressure is like, so when you set a respiratory rate of 12 to tell the patient needs to breathe 12 breaths per minute, mandatory, no matter what. Patient needs to get a tidal volume of 500 every breath. Every 5 seconds, patient needs to get a mandatory tidal volume of 500. Okay, roger that. Now, how do I deliver the volume? Is using my peak flow, which is in assist control mode. If you have a peak flow of 60, it is set at 60. It's going to deliver that. Now think about it, guys. I am given a task, a job, to take 2 bags of tidal volume to Kristen. Okay, my target is Kristen. I'm gonna say, here you go. This is to help expand your lungs. And I'm the peak flow. I'm going to bring it to you. Okay. I have no resistance now, but imagine there's 2 people in front of me, and they're not willing to move. Now guess what? I have to hold that 2 bags of tidal volume in hand, and I have to push through them. Okay, which takes what? Pressure. Indirectly, if you think about it, energy. That means I have to bypass them, take the strength to get to Kristen, right? Now think about having 4 people behind him. Think about the amount of energy that I have to spend to get that tidal volume to target, push them through, right? Why is that? So that is called pressure, the amount of pressure that is generated to push that volume of air to go into the patient's lungs. People are saying, hey, I'll get it there, but the pressure is there, okay? Peak pressures take into account of everything. So that's the difference between plateau pressure and peak pressure. If there is a kink in the ET2, do you think I can deliver my tidal volume effectively to the patient's lung? I will try, but guess what? It's going to take a lot of energy, which means what? Pressure, to generate that and push it in there. I'll try because that's what you told me to do. If there is water in this tubing, which condensation happens, do you think, and now my diameter of my blue tubing, which is inhalation part of it, is compromised, do you think I can effectively push the volume of air into the patient's lung? I will try, but it's going to take a lot of energy, a lot of pressure to bypass that water. So think about it. Peak pressure does not differentiate, oh Jerry, I know exactly where the problem is. The problem is in your lungs. No, peak pressure is going to alarm. When you after set limit, it's going to alarm no matter what the obstruction is. You have to, as clinicians, you have to figure out where that obstruction is coming from. Is it lungs or is it external? Okay? So if a patient, for example, if a patient is coughing, peak pressure is going to do what? Go up, because what is coughing? Blocking. Ventilator is trying to push the air in. I'm saying, Jerry, I'm hitting this obstruction. Boom, high peak pressures. Kinking in the tube, condensation we talked about. Now, how do I know if my peak pressures are greater than 35, 40, that means there's an obstruction somewhere. We agree? There's an obstruction somewhere. Now, how can I separate the obstruction? I check the tubing, I said, I don't see any obstructions here. Everything is fine. There's no water in the tubing. The tube is not kinked. His head is like hyperextended. Maybe, especially with morbid obese patients, when they have thick neck, it kinks the ET tube inside, which you don't see. So always hyperextend, take the pillow off, put a towel behind the back, and then hyperextend. That alone will prevent the peak pressures from cycling too much. You did all that, peak pressure is still high. Then guess what I'm going to do? I'm going to do what? Plateau. Oh, you can suction. Yeah, you suction. Very good. Suction, 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 everything. still not going down. I'm gonna do a plateau pressure, because now guess what? I did all that I could, but now I think it's internal. So when I do a plateau pressure, it's greater than what? Greater than 30, which means my problem is in my lungs. So when you're doing lungs with the physician, you're gonna say, hey doc, my peak pressures are getting 50s, which is more than what it used to be. They're supposed to be greater than 35, no more than 35. My plateau pressure is reading 30, 35, 36. He's automatically thinking, okay, lungs are going shut. Lungs are getting, instead of doing this, lungs are getting stiff. Okay, let's do sedation, let's do whatever, pulmonary toileting, bronch, let's do bronch, whatever. So that's why you have to differentiate between peak pressures and plateau pressures, and so on and so forth. Any questions about that? Makes sense, right?
It will always give the 500 tidal volume, right?
No, okay, good. I was gonna get to the more, but
Okay.
I will tell you, yes, since you already talked about it, we'll talk about that now. Yes, it doesn't. So, so depending on which mode, if you're on the volume control mode, so think about it this way. I'm a skinny guy, I don't have much energy, but I have enough energy to make it to Crystal with the 2 bags of volume of gas in my hand. Okay, now there's obstacles in my way, 3 people standing in my way, and guess what? I'm like trying, I failed. Which means I can never make it to my target. If my ventilator, the flow reaches the pressure too high, if I'm pushing through that obstacle, and if the pressure generator reaches a set alarm set pressure, it cancels off. Because why does it cancel off? It's not going to deliver the package to Kristen. Why? Because it's going to cause lung injury. If I don't set an alarm limit for my peak pressures more than 50, if it goes more than 50, and if it still bypasses through that, it can cause a pneumothorax. So that's why ventilator safety mechanisms where, yes, I want to deliver the tidal volume of 500, but my peak target pressures are rising quickly while I'm delivering it, it'll cancel that off. Which means patient's not going to get 500, whatever, maybe 200. Hey, here's catch it. You know what I mean? Kind of like that, you know?
And that's when you'll get the low tidal volume.
That's when you get the low tidal volume, because it's failing to deliver that. So if I'm always giving Kristen 200 instead of 500, do you think she's oxygenating and ventilating effectively? No. So then I need to paralyze prone, whatever I need to do. Makes sense? So yeah, we can go to the next one. So quick, summary, but we already talked about kinking, popping, pulling up condensation, whatever. Decreasing the ET tube diameter. So if you have a big guy, and you have a size 6.5 or 7.0, sometimes you see them with that. And you can tell them, hey doc, I think lump plateaus are fine. I think this tube diameter is a problem. Bronchospasm, decreased lung compliance, pneumothorax, we don't talk about that. Okay. All right, we can move on. Again, causes of peak pressures, anything greater than 50, guys, is pneumo territory right there, so you don't want to do that. Okay, we talked about that, check plateau pressures by allowing inspiratory pause, which I'll show you when we're doing the bench modes. So we can skip all that. Okay, let's talk about the fun stuff that you guys are always running into. There is different modes, guys, and every mode has a purpose. Some modes have been outphased based on new research and whatnot. So I may not touch about some modes in details because you may not even never use it, but it's nice to know. So there's different modes, right? There's the most common modes you will run into is in this Sherman Hospital. The most common modes you will run into is assist control, CPAP, PRVC, and seldom APRV by basic. SIMV. Dr. Jordan, everybody's frowned upon, so not enough research data saying that it's any better than any other mode, so they're not even going to use it, so I'm not going to worry too much about it. But anyways, what is in assist control, there's 2 variables, okay? This is assist control. We can talk about assist control. There's 2 variables in assist control. One is volume, okay, the other variable is pressure. I can either deliver a set tidal volume to your lungs. Okay, I'm going to deliver 500 cc tidal volume to your lungs. Or I'm going to say, I don't want to deliver 500 cc tidal volume to your lungs. I want to control the pressure that is generating. I want to control the amount of pressure that's going into your lungs. So you may think, oh, Jerry, which scenario calls for which? Or what? If you think about it, okay, let's move on to assist control mode. In the assist control volume phase, so that's why you always have to, when you're giving a report, you have to be more specific on when you're giving a report to the oncoming nurse, what assist control variable are you selected for this patient. That's why oftentimes we say ACVC, which means volume control, or ACPC, which means pressure control. That's what I'm controlling. If VC is volume control, that's what I'm controlling. VC means pressure control. So anyways, so let's take a look over here. You can skip on to the next slide. I think they're talking more about, okay. In the assist control ventilation, AC/VC mode, okay, let's focus on that variable volume is control. I have a set respiratory rate. Everybody agree? You have to have a set respiratory rate to ventilate a patient, right? Now, since my volume is the constant and not variable, it's my constant. So guess what? I'm based on the patient's height, ideal body weight. I'm gonna determine this patient needs 500 cc volume. And that's my constant variable, which means it's not moving around, it's just constant. Every breath, this patient is gonna get what? 500. Okay, now you have a PEEP, which is also, most of the time it's constant, PEEP of 5, unless ARDS kicks in, then you may manipulate that. PEEP of 5, FiO2 21%. In AC/VC, the difference between AC/VC and another more I'll show you, in AC/VC, we have what's called a peak flow. Okay, typically your peak flow is set at 60 to 120. The base is 60. 60 means, again, peak flow, what is the purpose of peak flow? It's basically telling the ventilator how fast to deliver the tidal volume. Peak flow determines my IE ratio. If my patient is COPD, guess what? I'm going to manipulate my, again, I'm not getting too detailed into peak flow because you're not going to touch it. RTs play with it. But I'm going to manipulate my peak flow if it's COPD. I'm going to manipulate my peak flow to lower standards if it's an ARDS patient and whatnot. So I have the autonomy to if it's a normal patient, no ARDS, nothing like that, then I typically keep my peak flow between 60 and 50 and 60 to deliver the tidal volume. Okay. Now think about it this, guys. Okay. So what's going to happen is, this ventilator is saying, Jerry, thank you for the order. I'm going to follow exactly to the T. Every 5 seconds, I'm going to deliver this gentleman 500 cc tidal volume. But what is my variable here? The pressure. The invisible force that you never see is the pressure, which you can see in the ventilator. It's reading 40 here. So the peak flow will take the volume of air, gives secretion, push it into the lungs, but guess what? Along the way, there's a lot of secretions, a lot of mucus plugging. It takes so much energy to push that volume of air into the vision plug. And guess what? That obstruction internally shows that the ventilator has peak pressure of 40, okay? Or 41 for now. Remember, the goal is to keep peak pressure less than 35, okay? Now, in the assist control mode, this mode, volume control mode, this mode only knows one thing. Deliver the tidal volume at a set rate, at a set frequency and whatnot. If the patient is awake, okay, patient is awake and say, doing this. So this machine, that's why it's called assist and control. Assist means if I know you're triggering a breath on your own, I know your subpropofol is down to 5 instead of 25, the propofol is down to 5, I know you're triggering a breath because you're waking up, guess what? Ventilator's going to say, okay, all right, deal. Guess what? You're triggering your own breath. Because you're triggering your own breath, I'm going to deliver the tidal volume that was promised to me to give to you, which is what? 500. If, let's say, and all of a sudden Kristen is acting up, she's rowdy and going all that, I'm like, oh, you know what, Kristen, you're not ready to come off the ventilator. I'm going to knock you out. I'm going to crank up my propofol to 55. All of a sudden, guess what? Kristen is out. That's okay, because guess what? My C part of my AC kicks in, which is my control variable, delivers the set tidal volume no matter what. So if you want to trigger a breath on your own when you're not on sedation, sure you can, but guess what? I'm going to give you the same tidal volume, because that's what I was promised to give you. The problem with this mode is, think about it for a second. Go to the next slide if you can. Keep going. Yeah. The problem with this mode is hyperventilation. The problem with this mode is air hungry, okay? Because you are awake and you can take a deep breath on your own, guess what? In this particular mechanic, see how this is machine breath? This is the, let's imagine this is the pressure, but imagine this is the tidal volume going in, okay? You have 5 seconds, right? 1 second of inhalation, so as the machine is coming down, so imagine this is the machine breath. As the machine is exhaling, guess what? Patient triggered another breath. And guess what? Machine said, oh, I sense a trigger. Here's a 500 cc volume. Before it can completely come to a exhalation phase, another breath kicks in. This is called the assisted breath, which is patient's breath. And all of a sudden, the time cycle to stimulate another breath from the machine already reached to that point, another breath is coming. So the volume never changes, 500, 500, 500, 500. What happens if my patient's hyperventilating? What happens to my patient's lung volume? Hyperinflation. This patient's gonna get more volume than it used to be, and I don't want that much volume because my standard volume is 500. Because this ventilator only knows one thing, to deliver the same set tidal volume, whether you're awake or not, it's gonna multiply the volume of air in your lungs. And that causes anxiety, air trapping, can't really communicate to you because you're intubated, you know, she's or he's intubated, whatever. So this is, and then also guess what? If I'm a big guy and I want to draw a lot of volume of air, because I breathe generally deeper, I cannot, because guess what? What's my flow set at? 60. I'm saying, I don't care, dude, you can take a whole breath through this tubing, but I'm only gonna give you little puffs of 60, that's it. But what if I'm a big dude? I need to take deep breath, deeper flow to get the volume in. I'm not gonna give it to you because it's limited by 60. Okay, so that's why oftentimes in this mode, patients can go, oftentimes they can go air hungry. So that's why they developed another new mode, which is the most commonly used mode in your ICU setting, is called the PRVC. You guys
Would
remember that?
that mode show like an asynchrony on the vent, or not really because it's doing what it's supposed to be doing? Does that make sense?
Yeah, so the asynchrony oftentimes comes in as high peak pressure.
Okay.
Yeah, because now, guess what? More volume sitting in the lungs than there needs to be. Patient is trying to be awake and trying to breathe, exhale, and also trying to trigger conflict of interest. Peak pressures keep going up, and waveforms are also changing in here. So again, you don't have to go too detailed about the waveforms, but so that's when you say high peak pressure going up. So oftentimes you say, doc, he's not tolerating it. Respiratory rate is 30. Okay, all right, put him back to sedation, or let's change him more to ACVC or PRVC. So let's skip all these couple times over, and I'm going to talk to you about. I'm going to talk to you about PRVC. Yeah, let's get that. We'll go back again on that. Okay, PRVC. Go back. One slide. So let me change this mode to PRVC. And is that what you guys use here now, anyways? PRVC.
Most of the time,
Most
yeah.
of them.
Okay. All right. Watch this, guys. I don't know if you guys can see that far, but let's see. Volume AC. What is my set peak flow here? 60. Everybody agree? I'm going to switch this to PRVC. Tell me if you see any difference. Okay, AC, PRVC, mode accept. What do you see on the bottom screen? Huh? Inspiratory time, right? I don't know, sorry, I don't know. So there's inspiratory time here, but what is the one missing parameter, peak flow? The flow is not there anymore. So guess what? This is an intelligent mode, which is actually better mode. That's why physicians oftentimes like it. But guess what? This mode has different names in different hospitals, different manufacturers. The VIA calls it PRVC.
Dr. Wu is here, Dr. Wu?
Puritan Bennett, 890 ventilators. I think the conversation is for you guys to have that here too. I don't know, but I think that's what they said last year. But anyways, Puritan Bennett, they turn PRVC into VC+. So it depends on which hospital you work. The concept is all the same. Companies change the name because of proprietary reasons and whatnot. So PRVC, VC+, are all the same. What PRVC basically means, this mode is a little different. You still have a set respiratory rate, agreed? No different than the ACVC mode, Taylor mode. You still have a set tidal volume of 500, okay? Now the variable here over here is like it's a inspiratory time. You don't see a peak flow that is set. Peak is still the same, FIH is still the same, no changes. In this particular mode, what it actually does, even though I told the ventilator specifically to deliver 560 tidal volume, the ventilator is going to say, Jerry, I got the message. I'm going to deliver the tidal volume, but guess what? I'm going to assess that patient's lungs, internal pressure, breath to breath, every breath to breath, and eventually I'll reach to the target tidal volume. Does that make sense? Because if this patient doesn't need, so what it ends up doing is it gives a set amount of tidal volume, let's say hypothetically 200, okay? Instead of the 500, it's going to start with 300, and it's going to say, okay, at the end of inhalation, it's going to measure the lung pressure inside the lungs and say, oh, okay, looks like the pressure inside the lung is not bad. Remember the plateau pressure we talked about? Oh, it's not that bad, it's less than 30. Okay, guess what? In the next cycle of breath, which is the next 5 seconds, I'm going to, instead of 300, I'm going to give 350 and assess the internal pressure. Oh, okay, still pressure, peak pressure is reading less than 40. Okay, I like that. Third breath, it's going to cramp it up to 400. Fourth breath, 450. Eventually, guess what? It's going to reach the target volume of 500. Which is a good thing because guess what? It can sense the pressure inside your lungs. It doesn't go like ACVC, the previous mode. If In the previous mode, if it feels resistance in your lungs, guess what? It only knows one thing to do, and that's why it's called stubborn mode. It only knows one thing to do is jab that pressure in, jab that volume in, because that's what Jerry told me to do. In the previous mode, all it does is basically, guys, take the tidal volume, force through that resistance and give it to you, despite the high pressures alarming constantly. And again, it cancels off, but if I don't set the alarm limit to more than 50, guess what? It's gonna blow our lungs off. See what I'm saying? But this one, on the other hand, it measures the pressure by breath by breath and eventually gets it out. So that's one beautiful thing, right? So hyperventilation is not usually a thing in this one. The other thing about this is it doesn't have a peak flow here. There's remember the set number of 60, it doesn't have that. Because it does not have that, patients often don't get air hungry because there's no limiting flow. You can suck however many volume of air you want, not however many volume of air. The depth of air you want to grab, like that, there's no limit to that flow. You know, it's all up to you. If you're strong enough to draw that much depth of air, sure, go for it. But, you know, there's no limiting factor. That makes sense?
Inhalation. Like, at the bottom.
In the front and the back.
Oh, gotcha, thanks. So that's where it is. Anyone have any questions regarding this? PC and ACPRVC and VC, just regular VC mode? I know it can get confusing, but oftentimes the go-to mode nowadays is ACPRVC mode because pressure constantly changes to eventually get to the tidal volume efficiency. Okay. All right. Let's talk about.
When would that not be? So like when they're stacking their breaths, like when you're not able, like that is.
Yeah.
what
So
we
even
do.
even when they trigger a breath on their own, okay, even when they trigger their breath on their own, this ventilator still gives that 500. Okay, still gives that 500. So breath stacking can still happen. Depends. So that's what these modes, honestly, guys, you know, cannot be used as a meeting mode. What is your meeting mode? CPAP, right? Because if I were to put a patient on assist control, regardless of PRVC or VC, just VC, what happens is, you know, if I want to independently breathe on my own, ventilator is going to give that mandatory breath that is already programmed. So that's going to cause hyperinflation, breath stacking, anxiety, all that. So eventually, if you're going to fully take the sedation off, you might as well put them on CPAP and just let them breathe comfortably. Okay, we'll talk about CPAP. All right, so let's talk about SIMV mode, which you can go back quite a bit. Yeah. Okay. Keep going back one more. Yeah, that's fine. Go forward. Actually, that's fine. Okay. So let's talk about SIMV mode. I personally like this mode. I know hospitals.
I think some of our doctors do now. Like if nothing else is working, the
Oh, they do?
intensivists will use it every now and then. During COVID, we at least did.
Yeah, good. Okay, so the difference in this mode is SIMV PRVC, or you can do SIMV, that's fine. So SIMV, what does SIMV mean? SIMV means synchronized intermittent mandatory ventilation, synchronized intermittent, so it's a fancy word, okay? So basically, similar to your assist control mode, you can still have a set respiratory rate. You can manipulate the tidal volume to 500. You can put the peak of 5 and keep the FIU to 21% or whatever you want. The variable, the difference between assist control and pressure SIV is that this factor right here is called pressure support ventilation, PSV. You see here pressure support of 10. Can you guys see that? So in this particular mode, the difference is when Kristen is completely sedated, guess what? It's going to work as an AC mode. Guess what? Because it's still going to give you the right rate of 12 over a minute. It's still going to give you 500 cc tidal volume with every breath. No questions asked. But let's say Kristen finally is waking up, her surgery's over, she's waking up, right? Now Kristen said, oh man, I want to trigger my own breath, but I don't want that 500 cc tidal volume that the Jerry programmed. I don't want that. I don't want that much. I just want 200. That's the beauty of this mode. It prevents hyperinflation, it prevents breath stacking because what's going to happen is she's still allowed to trigger a negative breath on their own. But ventilator is going to say, hey Kristen, I see that you're trying to trigger a breath on your own. I want you to take whatever volume you can. Whether if it's 100 cc, 50 cc's, 200, 300, I don't care. Whatever your lung is capable of, you can do that. So there's not always 500, 500, 500, 500 causing hyperinflation. There's 500, then there's 300. So if you go to the next slide, sorry, you can see the volume here. So no trigger means, imagine this volume, this is a volume curve, you know, it's a 500 cc tidal volume. and all of a sudden this negative deflection here, you can see this patient is trying to trigger a breath on her own. Ventilator's gonna be like, that's fine, go ahead and trigger it. Whatever you wanna breathe in is fine. So she's only able to take that much volume. But see the difference? Now, she stopped triggering, and all of a sudden, if she wants to trigger more, she can do that more too. So the ventilator is going to say, you know, if you're triggering on your own, your volume changes. It can be anything, whatever you want to draw. But if you're not breathing, guess what? Don't worry, because I'm going to take over anyways. So the volume always changes. You know, it's not, it can be constant if you're sedated, but if you're not sedated, it can change depending on how you want to breathe. The beauty of that mode is like you exercise your lungs. So where does PSP comes in? Pressure support comes in. So imagine if Kristen wants to take a nice deep breath on her own, what's going to happen is I have to facilitate that opportunity for her. I would just say, you can imagine guys, you and I, we're all breathing directly the atmospheric air from our mouth here directly to our lungs. She has to breathe into this whole tubing, tight space, while she's semi-sedated, semi-unconscious. How is she going to pull volumes if she wants to? So you have to overcome what's called tube resistance. Remember, this is a long straw. Taking water through a long straw is painful, right? You're going to exert a lot of energy. How do I overcome the tube resistance? Is by giving a little push of pressure support of 10. Make sense? Little extra push, saying, okay, Kristen, I see that you're triggering. Here's a little push. Anytime you take a breath on your own, the pressure support of 10 kicks in, gives that little assistance to overcome the tube resistance. Does that make sense? So that way she's not struggling to take her own breath. I like this mode better because open heart patients, most of the time they use this mode. You can skip it, yeah. Open heart patients, they use this mode a lot because they're not here to have, they don't usually have guards, they don't have pneumonia, they came in for surgery, 5 hours later you're extubating the patient, calling it a day. In that 5-hour time, they're not fully sedated either, so in that 5-hour time they can exercise their own lungs. Because imagine if I were to mandatorily give you the breath all the time, lungs are like muscles, guys. If you don't use them, you lose them, right? Same thing. If someone is breathing for me, why do I need my lungs? Hey, you're doing all the work, so I'm just going to be relaxed. The minute I put them on CPAP, they're failing CPAP because overnight the patient's been comfortably breathing, someone was breathing for it. So this exercise sufficient. So it's good for surgical patients with no lung issues, meeting modes. So my previous experience at the surgical trauma ICU in Lutzman, 99% of the trauma surgeons, they all used SIV. Again, it's not a bad mode, it's a good mode if you use it for the right intended purpose. And also it helps the cardiac output. Yeah, go ahead.
Sure, can I ask, so with this mode then, the SIMD,
Yeah.
just so that I'm understanding, so the patient can trigger their own breath and trigger their own volume, but the ventilator won't support, so if they've taken 300, it won't give them the extra 200 for it, it's just they're gonna get that 300 and they trigger
300, so yeah, very good. So let's say 5 seconds is here, 5 seconds, ventilator give a breath. Within that 5 seconds, you're awake, because it takes about 5 seconds. So 1 second for inhalation, 2 seconds. The minute the peak flow kicks in, it gives the volume of air to the patient's lung, the 500, inhalation is stopped. Then everything else is passive, exhalation. So while that volume is coming out and you want to trigger another breath on your own, you can, but the volume is not going to be 500, it's going to be 300. But soon after the exhalation phase is over, the ventilator is going to still keep that 500. You know what I'm saying?
Yeah.
So it cycles within that time frame, 5 seconds, 5 seconds. But in between that, if you want to, and also this ventilator is smart, good point. If it comes close enough to that next breath, it cancels that patient's triggered breath because it's so close to the next volume, so it'll keep that 500 instead of that 200.
Okay.
You know what I mean? It's kind of confusing, but yeah. So I guess in a way, this is, and also it helps decrease cardiac output. How does it help decrease cardiac output, guys? Can you talk about it?
Probably that venous return, so you're.
Yeah, because think about it, positive pressure, every breath, positive, every 5 seconds, positive pressure, positive pressure. Man, come on, give me a break. Let me take a breath on my own without that high positive pressure, right? Of course.
It's kind of almost like assisted CPAP. Almost.
Assisted CPAP, yeah,
Right?
yeah. And if you're not breathing on your own, guess what? That's okay. I'm going to kick into the assisted control mode of it. Yeah. Okay, so let's move on to, we talked about PRVC. Let's go back to pressure control, which I think most of the time you guys will use that too. Yeah, pressure control. Yeah, you can go back again. This is control. Yeah, keep going next. Pressure control. Okay, keep it at pressure. So, all right, mode. We're gonna do ACPC again. There's ACPC. There's SIMVPC. My God. So ACPC. So let's go mode for argument purposes because this is what the most commonly pressure control mode you guys use. So let's focus on that. When do you think I should do pressure control over volume control? Because what am I controlling in the ACBC? My volume. 500, 500, 500, 400, 400, 400, whatever. In assist control PC mode, AC PC mode, what am I controlling? Volume or pressure? Pressure. Very good. AC, PC, same thing, but now it says pressure. Do I see a volume here? No, because what is the variable now? What fluctuates with every breath? No, volume. What is always constant? See, what am I controlling? My two variables, right? I can deliver X amount of air into the patient's lung by two factors, pressure and volume. Before the mode was all volume driven, controlling the volume that goes into your lungs. Now I said, you know what, I don't care about how much volume goes into the lungs, I need to control the pressure that's going into your lungs. So what am I controlling again? Pressure. That's why you see inspiratory pressure of 15 here, okay? IP of 15. Now tell me, why do I need to control pressure? Why don't I care about Kristen's, I'm sorry, I'm using you as an example, but why don't I care about the tidal line fiber going to Kristen's lung, but instead I care about the pressure that's driving that volume into the patient, into Kristen's lung is more important to me, more so than the actual volume going in. What do I?
Lung compliance.
Bingo.
Like
Bingo, lung compliance.
inflammation.
Lung compliance, right? So think about your normal patient picture. Comes in with pneumonia, you did everything, forgot to stop the antibiotics on day 4. Still on day 4. Pneumonia got worse, or patient didn't show up for 4 days, and then the ARDS picture is already kicking in. Initially, you are on ACBC mode. Lungs are compliant enough that it's able to expand. But now you know this patient is in ARDS. How do I know this patient is in ARDS? What did I do?
The PF ratio.
PF ratio less than 200, right? There you go. Bring attention. Yeah. 200, right? So the and PaO2 of what? Less than 60, right? So okay, all right, guys, we need to do something about this. Now these lungs are getting stiffer. If these lungs are getting stiffer, can I jam that 500 cc tidal lung into the patient's lungs? Because that's what I told the ventilator to do. The ventilator is going to follow your direction every step of the way because it's like a robot. It's going to do it. But what happens if I do that? Better trauma. More importantly, that leads to pneumothorax. So guess what? That's why ARDS patients who are stiff lungs or getting into the acute ALI phase, acute lung injury phase, between 200 and 300 range, time to flip them on. Pressure control. Why? Because now I need to control the driving force that drives that volume into the lungs, because if I don't control that bad boy, he's going to puncture my lungs. The force, right? So the force is what I'm controlling now, which is pressure. So that's why I need to, the rate is still going to be the same. I still need to ventilate the patient because, again, our standard respiratory is about 12 to 20. So I'm going to still ventilate the patient with a respiratory rate of 12, or ideally in this situation, if it's ARDS picture, what's my respiratory rate is going to be? If it's ARDS picture, high, right?
Wow. That escalated quickly, Jerry.
This is called being trigger happy. Let's just say 28, that's pretty standard. Okay. Inspiratory pressure, okay? How do I determine how much pressure should I give to Kristen's lung? Can I just start with 1, 2, 3? No, right? So the way I determine the pressure is because remember guys, my ventilation is still my important factor. I still need to open up our lungs. That's my ultimate goal. How I do it is not the point. I just still need to open up our lungs. But I don't want to open up our lungs by forcing that air into the lungs and causing damage. But I still want her to get bare minimum. So if 500 cc is what your body lungs needs, I still need to give her at least close to 500 or 450 or 480. I need to at least get there. Because what's the point? Otherwise you're not ventilating. You're going to go cyanotic and you're going to go into respiratory arrest. What's the point, right? So how do I do that? So my peak and my inspiratory pressure. I'm going to click on my inspiratory pressure. I don't know if you guys can see. VTE means exhale tidal volume, VTE. Watch that number. Right now it's reading 140 cc's. That patient is getting, this test run is getting 140 cc's of air. Okay? Watch this. The minute I increase my pressure, the driving force, watch this. Even 20. Watch my exhale tidal volume.
Oh.
You see that? So what does that mean? Volume is the variable factor. because I increased the driving force, I'm giving the patient a little bit more tidal volume. But is 200 enough for Kristen? No. All right. You all agree? I'm going to go to 25. 270. Okay. Let's bring this bad boy down. 20. Okay. So typically, remember, what is the peak pressure we always want to maintain at? Less than 35, right? Less than 35. So if I know that less than 35 is perfect for my lungs, that's what I'm going to do. Okay, I'm going to keep it at 30. Okay. 360 tidal volume. But you said, Jerry, less than 35. So I can still go up to 35. Inspiratory pressure, I can still set it at 35. But I'm not going to. Why? Because I already know this patient is getting 35 inspiratory pressure. How do I know this patient is already getting inspiratory pressure of 35? It clearly tells you inspiratory pressure of 30, and I want to set it at 35, but I'm already telling you that it's already at 35. You say, Jerry, no, the number doesn't make any sense. What is my other, where's my other 5? Heat, yes, remember, positive and expiratory pressure. It's also a pressure, guys. 30 plus 5, 35. So anytime you're communicating with a physician or respiratory therapist or giving shift report, you cannot just go and say pressure control of 30. No. What is the true pressure the patient is getting? 35. Always make sure you add 30 plus 5, 30 plus 4, whatever the case may be. 25 plus 10, 30, 35. So you always have to take into account this pressure and this one to get the true tidal volume. So guess what? I know no matter what, her arched lungs is still going to get a tidal volume of 360. That is now guaranteed because I'm controlling the amount of pressure. But I can never get up to 500. I can get up to 500, but guess what? I need to crank this bad boy to 435 or something. See? Now my alarm limit is saying, hey, circuit disconnect, circuit. Anytime you see circuit disconnect, guys, well, in this earlier scenario, it was true. The circuit was actually disconnected. But most of the time, if we don't see any disconnect, and if it still shows the alarm circuit disconnect, what does that mean? Airway obstruction. I know, it's worded poorly here. Other ventilators don't show that circuit disconnect. But if you see circuit disconnect, that means now I increase the pressure, it's having a hard time forcing that air into the lungs and it's canceling off. So it's like, that's what it's saying basically. It's saying, hey, listen, I'm having more obstruction. And now it's mimicking as a disconnect, even though it's not. But guess what? Because I'm controlling the pressure, my volume is always going to be 400. Okay, it's always going to be variable, it's always going to change, but my controlling factor is my pressure. So now I got to 400 off that line for her. But I don't want to keep it at 400 because my pressure, 35 plus 5, 40, that's a lot. So I'm just going to leave it at 30 and just call it a day because at least some ventilation is better than what? No ventilation. Okay. That's why oftentimes when you're in this mode, you oftentimes, if the presentation is bad, also you're pointing this patient to paralyzing so you can have better control of the pressures. Okay? Sedation is a big factor. All right. Who wants to go next to the slide? Is there an option? Okay, thanks. Yeah, reduce an arch patient, reduces the risk of barotrauma, pressure control. Yep, you can do next. Yeah, we can skip along that lines. As long as we talked about that. Yep. Yep. Oh yeah, go back for a second. Okay, mode, PRVC. Okay, remember what's the difference with the ACVC and PRVC? In the volume control, you have what? A set volume and a set peak flow of 60 or whatever. In PRVC mode, you don't have a peak flow. So this is what I was talking about. PRVC is a very smart, intelligent mode where it detects the amount of pressure going into your lungs, breath to breath. So initially, PRAW, PAW means airway resistance or pressure, is what it's calling at. You're looking at, initially the ventilator only gives the patient a small pressure, okay? It gives a small amount of pressure to see what the airway resistance is looking like, or internal plateau pressure is looking like. But because I only give small pressure, guess what? This is my target tidal line, the dotted line. Did I reach my target tidal line? No. Because I gave a small pressure, it only delivered small tidal line. 5 seconds later, my next breath kicks in, guess what? Okay, I think the lungs are not that stiff as I thought it would be. I'm gonna give a little bit more pressure. Because I gave more pressure, guess what happens to my tidal line? Slightly more elevated. Because I gave more pressure, guess what? I finally reached my target tidal line. So it detects breath, detects patient's lung compliance breath to breath, and then determines that whatever the patient needs it. So it doesn't go crashing hard like ACDC. Okay, all right, so we can go to the next one. All right, so this mode, have you guys used this mode recently?
I
Anyone
haven't
think it's
seen it since COVID.
Yeah, that's the last one I remember.
Usually, it's the endo, I call it the endo, be all. Usually it's the last resort, if you will. So, without confusing with all the terms in itself, it's basically this type of APR, the airway pressure release ventilation mode, is basically used on patients who are severely hypoxemic. You're having a hard time ventilating. So remember, talk about ARDS. What happens to ARDS? Right now you're on VC mode. How do you know this patient is going to ARDS mode? ARDS?
The PF ratio.
PF ratio. What is your plateau pressure? Is it high or low? High. Beautiful. Very good. What about your peak pressure? High or low? High. Everything is stiffening up. PF ratio is in the toilet. Guess what? What mode did you switch into? You switched into pressure control mode. Because that's a transition. So from ACVC to pressure control, because I don't want to jab that pressure in. I need to control the pressure. So I'm controlling the pressure. I need to put it on PC mode, which I did. And I honed in, did all that pulmonary toileting work. Day 14 comes, still not effective. PA, which is still less than 60, all that kind of stuff. Lungs are still resisting. Guess what? Endo will be open what is the biphasic mode. So patients who are severely constricted, there's no expansion at all. That's when this mode comes in. So you can go into the next phase, next page. So this particular mode has two settings. I call it the glorified CPAP, continuous positive pressure. Basically all I'm doing is, there's two settings. High CPAP setting, low CPAP setting. And there's two time factors, inspiratory time high and inspiratory time low. So I would set a night time, for example, I would set a P high, which is a CPAP mode of 20, and an I time of, let's say, 10 seconds. In that 10 seconds, what's going to happen is the ventilator is going to force the pressure of 20, which is CPAP, if you will, opens that lungs and keeps it there, like this, just keeps it there. Okay, and you have still respirations will happen. So at 10 second, after the 10-second interval, it comes down back to low pressure of 5. It doesn't go back to 0, but we can never completely collapse the lungs. 5. And it stays like that for 5 seconds. After 5, or even 3 seconds. After 3 seconds, guess what? It's going to go back to high pressure of 20. Now that's ventilation, right? If you think about it. But it's not effective ventilation. The idea behind this mode is that I want to force open his lungs and say, hey buddy, stay awake for me. I'm going to help you because I know your lungs are stiff like concrete. I'm going to push open your lungs. Now I want you to be staying awake, and I want you to, when I push open that lungs for you, I want you to breathe in between that interval, that 10-second interval. So you should breathe in between that. So if you go to the next picture, I'll show you an image. Let's say T-height, 10-second interval, 5-second interval, 10-second interval, 3 seconds, whatever. So pressure of 20 is going into the patient's lungs, keeps it open, CPAP phase, keeps it open. These quickly marks that you see is ventilation. That's when the patient have to breathe in between that phase. That makes sense? The patients have to breathe in between that phase. If you completely sedate the patient, and all I do is just expand, open it for 10 seconds, 20, 10 seconds, and bring it down for 3 seconds, open, is not going to effectively ventilate the patient's lungs. In order to effectively recruit those alveoli, the patient also have to breathe in between that high pressure phase. Okay? The patient have to make their own breath in between that phase while I force your lungs open. Oftentimes, in that situation, most of the time patients are sedated, severely sedated, they're not going to be able to take their breath on their own. Permissive hypercapnia is very common in this situation where your CO2 already is in the 80s, 90s, 100s, because this is This mode does not, guys, all I'm telling you is like, when we had COVID situation, when we had patients on this mode, in order for this mode to work, you have to keep the mode at time. Time is a key factor. You cannot just put this patient on this mode and just say 30 seconds, the gas is looking worse. Yes, pervasive hypercapnia is expected. Your CO2 is gonna go high, it's expected. Give it 24 hours. Most of the time physicians are not comfortable with that because they want quick gratification, like, in a sense, like, oh, my numbers are improving, so they will revert back to what they already know, which is pressure control mode. Not in this one. In this one, you have to give them time. Unfortunately, the patients that I took care of in this mode never made it.
So is this like you're forcing the,
Yep. So all I'm doing is you're not opening your lungs. I'm opening it for you.
okay?
Okay? Think about the pressure goes in. I'm gonna say, hey, listen, I'm gonna
That
open
made
the
me
lungs.
dizzy, I don't like that.
Huh?
That made me dizzy, I don't like that.
Yeah. So
That
I'm gonna.
sucks.
Yeah, it sucks, right? I'm gonna open the because remember, your lungs are so stiff. Your own intercostal muscles, your own sternocleidomastoid muscles, they're not strong enough to even pull that chest open to take that deep breath in because they're so stiff. So I have to open it for you internally. So what I'm gonna do is I'm gonna give you that pressure of 20, saying, okay, hey, you got 10 seconds. I'm gonna keep it at that 10 seconds. Now, what if I keep it at 30 seconds? What's gonna happen?
Yeah.
You don't want that. That's why I quickly need to come back to the face because your lungs are, remember, these are very, very stiff lungs. So I'm gonna do everything I can to open your lungs. I'm gonna say, hey, okay, now breathe. But you're not thinking timing in your head, okay? Just so you know, you're not thinking, oh, okay, Jerry said 10 seconds now. I've got 10 seconds breathe. You're always breathing. Remember, you're already panicking, you're already breathing. All I'm doing is while you're breathing, I'm opening it up so while you're breathing, that effectively eliminates whatever CO2 we can in that time frame. Does that make sense? I know it's hard to understand this concept, but let me put it on. Okay. So let's do pressure high of 20. So low, pressure low of 5. Okay. FiO2, all that. All right, so let's try to see if I can mimic this in this setting here. Sometimes it's, see what I'm saying? Did you see that?
Yeah.
Did you see that the pressure stayed open for 20, the 20 of pressure went in and stayed that way? And I was triggering my circuit, my chest lung, and in that time frame, the patient is breathing, and you can see the squiggly worms, squiggly things, the waveforms going and going like that. So watch this. Okay, inhalation, and now breathing, see? Did you see that?
Yeah.
Boom. So that phase opened up for that X amount of time, and the patient is triggering breath on their own and breathing, and that's how they exhale their CO2 out. Okay, see, if I don't do nothing, it's just going to be a flat line and drops. A couple seconds, flat line, drops. See what I'm saying? It makes sense? So pressure of 20 for 10 seconds, drops, stays for low seconds or 5 seconds, whatever, goes up again, drops. But no ventilation is happening in that phase. The patient is not breathing. So that's why it's important for patients to be awake and be off of sedation so I can trigger that breath. See, look at that. See, in that phase, the patient is ventilating out. That makes sense. The volumes are going to be shot, guys. The volume's going to be 200s. Patient just have to trigger under rate. That's why you don't see a respiratory rate here. You see a T high, T low, P high, pressure support. You don't see a respiratory rate.
That's why it's more similar to the CPAP, because you're not controlling that respiratory rate. They are.
They are.
You're just helping with that pressure and helping with the
I'm opening it
oscillation
up for you.
rest.
I'm opening the door for you.
Okay.
I'm opening the door for you so you can quickly come in and out. Yeah. But that's why it's a very strange mode, because it's like an LVO kind of mode, because you can't even open up your own lungs. I mean, think about how stiff that is. Okay, so let's keep moving. Next one. Oh, sorry. Okay, so, okay, let's talk about CPAP mode. So what's your understanding about CPAP? When someone tells you, hey, go ahead and put this patient and say, let's do a spontaneous breathing trial. What does that mean? Yeah. Exactly. So when they say let's do a spontaneous breathing trial, you're thinking CPAP, right? CPAP. Yeah. So usually 10/5 standard, right? True weaning, then you're 5/5, and you can extubate after that. So in CPAP mode, okay, guys. So let's go to CPAP mode. Mode accept. Boom, everything gone away. What do you see? You don't see a respiratory rate. You don't see a set tidal volume. All you see is two numbers, and two numbers only. Which one is what? You still need your P, physiological P for 5, your pressure support of 10. What is that pressure support of 10 means? What do you guys think when they say, oh, Jerry, this patient is on 10 over 5? What are you thinking when they say 10 over 5 means?
So just helping give that pressure to help them get
Yes.
that breath in.
Yes, because why? Look at this tube. Look at the narrowing of the tube. You know, you gotta compensate for that tube compliance. You gotta overcome that resistance, because it's not fair for the patient to breathe on a long straw and say, oh, you're failing, because I'm not giving the benefit, because I don't have a straw in my mouth, but he does. That's why he's struggling, so you gotta give him the benefit of the doubt too, right? So typical safe pressure is always 10. See how it says apnea? Because if the patient, so in this mode, think about this, guys. If the patient, when you put somebody on pressure CPAP mode, 10 over 5, great, good job. And if the patient goes apneic, if you have 2 or more apneic episodes, do you think it's safe to put the patient on CPAP? Okay. So the patient is not on, so guess what happened? All of a sudden, did you see the respiratory rate of 20? This is a test one. He's not breathing on his own. So what happened? Why am I getting a rate of 20? Fail safe mode, default. Yes, you can put a default mode, automatically kicks in, because you're in around another patient's room, you know, sedating this patient, you know, ETOH or whatever. Your next door patient is going apneic, everybody's busy, nobody can keep an eye. Yeah, can you imagine this patient going apneic? So when does apnea alarm triggers? When you don't breathe for how long?
Like 8 seconds.
20 seconds. 20 seconds. So if you have 2 or more episodes of apnea, like 20, 20, 20, then automatically it's a failed attempt to put them back on. Or, can I just put them back on? What else can I do? Did you forget to do what? Yeah. Can I ever put a patient on CPAP with sedation on? Please do not do that. You can do prosthetics. That's because prosthetics cause respiratory depression. No, right? So what one medication you should not be running while you're on CPAP? And fentanyl, because fentanyl causes what? Depression. So it's counterproductive on this, right? So oftentimes I've seen in other class practice where I worked, they'll say, oh, he's tolerating CPAP and he's not going up, not going restless on CPAP. I'm like, oh wow, that's good. That's sanguinary extubation. Only to find out 275 mics of fentanyl running, and I'm like, that's interesting. So you're not supposed to do that, because yeah, patient is getting a picture perfect breathing because your patient keeping the patient comfortable. Let's turn everything off and see. Of course, fail CPAP. Pain kicks in, everything kicks in, no way. So be mindful of just don't go and change the number. Always communicate with RT, because you're not going to change this. Who's going to change it for you? Respiratory. Before, guys, this is where professionalism comes in, where before you call a respiratory therapist, you need to make sure you set up this patient for success and not for failure by doing what? Turning off sedation, fentanyl, whatever this patient is on, before you call the respiratory. Because respiratory therapists, if they call Jerry, can you come in for the patient on spontaneous trial? I don't know what's the medication. I'm not trained on that. I don't know what fentanyl. I know what fentanyl is, but I don't know how that works or anything. So I'm just going to say, okay, you told me to do it. I'm going to do it, and I'm going to walk away 20 minutes later. I'm not, because remember, one respiratory therapist for the whole hospital. So make sure your patient is ready, awake before you switch up to CPAP, so you can all get the benefit of being on CPAP. Okay. So pressure support of 10, people 5. Now, when do I know? Let's say, so if you see apnea, default mode will kick in, 2 episodes or more, put them back, no point. Or if sedation's all off and the patient is still apnea, put them back. Maybe because traumatic brain injury, who knows? Put them back. But when do I, so the patient's not going apneic, the patient's actually breathing, okay? When do I determine this patient is not tolerating CPAP? Okay, give me an example of is 24 is considered to, isn't it? Is 24 okay?
30.
Yeah. Now, intermittent 30s is okay. Sometimes even 35 is okay. Sustained, exactly. That's a key word, right? Sustained breathing, like 40s, like that. So imagine this, guys. If I'm sustained breathing at 40s and 50s, think about my metabolic demand in my body. The amount of work and energy that I have to take to breathe that much while laying in bed and not even running a marathon. When should you breathe 40s? When you're running, right? You're not even breathing 40s. You're just laying there and burning through calories. That's what you're doing. So it means the patient's not even ready. Okay? Or address the factors of tachypnea. Maybe it's just that patient had a spinal surgery and is in massive pain. Who knows what? Maybe if you address that, that could also help with extubation as well. Now, The other, what about other factors? Okay, so tachypnea is one of them, and you're saying, okay, that's not a criteria for passing CPAP now. What else? SpO2, okay, very good, faster, low, less than what? 94, yeah, okay, perfect. What else?
They're becoming really tachycardic.
Tachycardic, hypertensive, right? All those factors now, you're making this guy up, right? What's a very important number that you're looking at a ventilator for, besides tachypnea?
Their volumes.
Volumes, right. Again, remember guys, if this gentleman is supposed to breathe 500 and he's only breathing
Yeah, it's not enough
180,
volume.
200, not enough volume, so he's gonna be fish out of water, he's gonna, he's gonna die because he's not pulling volumes. He's not strong enough to pull volumes. So those are all, so tachypnea, low tidal volume, so those are numbers you're looking for. So classic indications to put him back. Now, that doesn't mean that he failed today, that doesn't mean that he's gonna fail tomorrow. You always have to give the due diligence of giving him a second chance, right? So tomorrow could be another day. That's what, communications key with families, like, oh my God, he failed. You're gonna tell him, it's okay, he's gonna fail, you're expecting him to fail. But tomorrow we're gonna try again, we're gonna strengthen his lungs. This is what I'll tell you, more importantly. If someone is on CPAP and not quite ready to get extubated today, can you put him on CPAP overnight?
Let him rest.
Dr. Flynn, this here, Dr. Flynn.
Physicians oftentimes not gonna hold your hand and say, put him on full support. They will if you ask them, but they're assuming that you already know that. Think about it, this guys. If I'm gonna extubate this gentleman here tomorrow morning, and that's my plan, why make him run a marathon overnight?
Right.
Why? What am I gonna achieve? Nothing, right?
Set them up for failure.
Set him up for failure. Exactly. That's why a lot of CPAP fail in the morning, because you're really letting him breathe on his own with pain and not moving around, and it's like, oh my God, so many thoughts going in his head. So yeah, let him, after 8 o'clock, 9 o'clock, automatically put him back in full support. Also, the other thing to keep in mind, if your patient is on full support on a peak of 10, it happens oftentimes, on full support ACVC mode, peak of 10, and you put him on CPAP, and guess what, CPAP is on 5, would you put him back on peak of 10? Yeah, because if he's already in CPAP of 5, why does he need peak of 10?
Right.
Again, this is not nursing fault. RTs oftentimes miss it, and they don't even pay attention. They will put back on the default, oh, yesterday he wasn't on this mode, so I'm gonna put it on. You have to be that nurse, go out of the way and say, oh wait, what PEEP are we running? Why do we need PEEP? Again, what does PEEP do? Decrease cardiac output, decrease causing low blood pressure, and you have to crank up on your medication. Why? Why do all that, right? So you think about that, you know what, if he can tolerate CPAP of 5, that means he can tolerate ACVC PEEP of 5. Makes sense? So that's one of the few things you can look for. And then of course resting, and then over in the morning time, make sure the patient is ready for extubation. 30 minutes of time during CPAP trial is not good enough to extubate a patient, okay? If anyone tells you that extubate the patient within 30 minutes, it's not always an ideal indication, because think about it, you're on fentanyl overnight, night shift comes in, everyone wants to be sleeping, fentanyl overnight, propofol overnight, calm and collected, all that medication is staying in your system, come in the morning, you say, oh, turn everything off, okay, I turned everything off, 30 minutes CPAP, oh, he's doing CPAP, good, let's extubate him. Is that a good time? Did that fentanyl completely wear off from the system? Did that propofol completely wear off from the system? No. So you have to give them a fighting chance. Don't just go prematurely extubate somebody and just say, oh, he's doing good, and then only to reintubate. That's happened many times. So just be mindful that 30 minutes of CPAP trial is not an indication. Okay, so let's move on to this thing. And the other thing, let's keep going. What's the other one? Oh, we talked about cool climate skin. That's something we didn't mention. Agitation, confusion, hypertension, tachycardia, anything like that, definitely not a candidate for CPAP for that day. Okay, so one more thing I was gonna talk about CPAP. I forgot. I'm sure it'll come to me. Okay, so troubleshooting events. Okay, so let's talk again. High peak pressure alarms. What are some of the factors that cause the high peak pressure alarms? You're walking into Kristen's room. Kristen is busy with another triple patient. You're walking into the patient's room. High peak pressure alarm. What's running in your mind? You don't know anything about this patient.
How's the call?
Okay. You're thinking obstruction of some sort. Do you all agree? Okay. Now your job is to make sure what type of obstruction, right? Why is it obstruction? So what would you start first? You start always very good. You always start before suctioning the patient. You always start with the patient and saying, what's going on? Is he biting the tube? He's awake. He's biting the tube. He's coughing it out. Whatever. So always start from here down to the tube. Okay. Now you looked at the ET tube. You looked at the neck, it's not constricting, you take the towel off, you put it back, okay, and you looked at the patient's drip going on because you're a nurse, now you can analyze which medications you're running. Okay, fentanyl is off, I see he's hanging it, propofol is off, okay, I think they're gonna try to wean it, that's what they're trying to do, I assume so. And then you come down the pipeline and you listen to his lungs, severe coarse crackles, okay, you know what? Everything else is not disconnected, I'm gonna suction it. Coarse crackles, I'm gonna suction it. Give it a hot second, always before suctioning, what's the first thing you need to do? I tell you to hyperoxygenate, okay? And how many suction attempts do you guys need to do each time? No more than how many? Two. Why is that?
Like clean and like recover after.
Sure. Yeah. What's the most important part? What does suction do to your?
You make them cough, and you got any type of
Huh?
therapy.
Oh, definitely. It's not a pleasant thing at all, right? You know, bleeding and all that. But most important is vasovagal stimulation. They drop your heart rate. So too much suctioning can cause vagal stimulation, drops your heart rate, and then you're going to get into more conflict. We just haven't countless number of times. So I would say respectfully no more than 2 attempts, unless you really think oxygen is dropping, you have to suction. Then yeah, go for a third pass. Most important thing, guys, I'll tell you this much: when you're already traumatizing the patient, when you're already suctioning the patient, make sure you're suctioning properly. What's your suction pass time with each insertion?
10 seconds.
Huh?
Isn't it 10 seconds?
Yeah, 10 seconds. So I'm gonna put the catheter in, I got 10 seconds to bring it up. Don't hurry. So most of the times I've seen nurses do this, or even RTs do this. Like this. Can you imagine? It is a tiny tube, thick secretion. Do you think I can even suck it out in one pass? No, take your time. You're already traumatizing, you might as well just do a good job at it. You know, just take your time, bring it out, okay, it's okay. And take the pink squirts, clean the tubing out completely, and advance it again and do that, okay? All right, let's move on to, if you see low tidal volume, that means that means either there's a leak in the patient's cough, okay, and you're gonna hear gurgly noise coming in, or it could be just a leak in the tubing or stuff like that, or it's probably disconnected and stuff like that too, so just look for that, okay? All right. Anything else? Let's see, any more? You can skip that, it's pretty self-explanatory. Okay, so don't forget, guys, ARDSNet protocol is low tidal volumes, IP, IFIO2, and definitely make sure a patient is adequately sedated and paralyzed for ARDS patients.
And make sure that your FiO2 is charted correctly in the computer as well, because the doctors usually do it themselves, not off of the AUG. And they've noted that, like, sometimes it says a different FiO2, so that it shows worse than it actually is.
Sure. All right, that brings everything to a conclusion and a halt. So let me talk to you quickly about the ventilator here. You know, this is definitely the Avia ventilator. It won't take too much time. Always know this blue is the inhalation tubing. Okay, blue. It's pretty standard. So any hospital ventilators that you're using, if you see blue and white, blue is always the inhalation port. White is the exhalation port. If you see a lot of these separations and stuff, all RT haven't changed. But if this patient is on a peak of 15 or 20, I wouldn't advise to change the tubing. Why? Yes. You know, guys, think about PEEP. I don't know if you ever watched the YouTube video of PEEP recruitment in big lungs. It's fascinating to see. It takes, so if you disconnect somebody or ventilator just disconnects itself, okay, what's going to happen is that much pressure that was holding the lungs open goes into a flat tire mode. Flat. Now, guess what? All of these alveoli you have to recruit, it takes forever. That's why even when you connect them back to people 15, guess what? You're not going to be able to recruit that oxygen. The oxygen is still going to stay low, so don't panic. Don't change the numbers. You have to give it a good 5-10 minutes, because guess what? It pop open the alveoli again, and that takes time. So the goal is, if you don't have to disconnect the tubing, unless it's really obstructing the tubing, then change it, call RT. If you have to take, you know, for example, disconnect the tubing, connect a vent, transport vent, what I would recommend is use the hemostat. Pinch the ET tube, or use your finger, pinch the ET tube after the inhalation phase. So when they take a deep breath in, after the ventilator gives a breath, hold it, disconnect it, tight it, so you're maintaining and holding the PEEP in the patient's lungs. Make sense?
That video is in our binder, our new pulmonary binder. There's a QR code to look at that video that he was talking about.
Perfect. Good. Oh, good. Thank you. This is another thing. So in an emergency, always know your backup equipment in the room. This is definitely an ambu bag, right? So oftentimes the ambu bag does not come with what's called a PEEP valve. So anytime your patient's on a PEEP of 7 or 10, always make sure you have a PEEP valve at the bedside, standby, ready to go. There's a little cap here, usually comes with it. So all you have to do is anytime you're bagging somebody because of bronchospasm or whatever, you're bagging the watch, make sure you're bagging with the PEEP valve on. So take that little cap off, literally pop it in, okay, and take this off, connect it to ET2. There's numbers over here, we'll tell you 5, 10, 15, 20, so if your patient's on 15, then crank it up to 15 or 10, and then you bag so that you can maintain the positive pressure in the patient's lungs.
Now always make sure that's hooked up to oxygen.
Sorry.
If you don't
You'd be
know how to
surprised.
do that, then we'll have a different calling
I
after
didn't
that.
mean to-
You'd be
Yeah.
surprised.
Oh, yeah, talking about oxygen, how much flow?
Yeah.
Yeah, no more than 15, crank it up, crank it all the way up. Don't puddle around with that 10, 12, nothing, no nonsense like that, just crank it up. Even with non-rebreather, crank it up to 15, make sure the bag is always inflated. Any questions, guys? Do you want me to go over the ventilator with you guys? Oh, actually, no, let me show you the plateau pressures real quick so that you guys can have an idea. Let's do AC/VC real quick and then we can be done. Okay, remember AC, I have a rate of, let's say, 12, 500, okay. So what I'm gonna do is, I'm gonna do what's called an inspiratory hold. So this is called peak flat, okay? Pay attention to the numbers, peak flat is plateau pressure, peak pressure. So I'm gonna hold after the, okay, wait a second. It has to be done at the end of the inhalation. Why is it not doing? Hold on a second.
And this is something that respiratory would do for us. We wouldn't do it.
Yeah, the respiratory one would actually. Oh, this is because the test lung is so much resistance that it's canceling out. Yeah, so it won't read now because the compliance on this is too high. So it won't read, so it's canceling off my inspiratory hold. It's trying to force it in. So anyways, so what happens is on a normal patient, when you hear the ventilator pushing the air in and you press the inspiratory hold, it'll stop giving another breath and it just stays there like that for 10 seconds and you will get a number. So if it's greater than 35, you write it down for your rungs and let them know, doc, this is my number, so. And I go from there.
Are you holding it down for the 10 seconds, or you're just pushing it once and
So this one, I hold it for 10 seconds, but the
Okay.
newer Puritan Bennett's, you just have to press it once, it just records it for you. So I guess depending on the ventilator you're using, but typically you can always ask which are they, can I get a plateau pressure on the patient, if you can remove it. What else can I tell you? So anytime you're transporting a patient, please be aware that, RTs, again, new grad RTs are coming in, so don't take everything what they say for granted because they're also new, they're also learning like you guys. The most important thing is if you're on 100%, make sure you have a full tank going for transports. Oftentimes you get stuck in an elevator and the elevator doesn't move, my God. Can you imagine with no tank? So grab your ambu bag with you, grab your PEEP valve with you. If you have to emergently bag a patient, make sure you do that in an emergency situation. So full tank, PEEP valve, everything going for transport. Cool. That's all I have for you guys.